Hello, my name is Rich Zellers. I am Chair of Radiation Oncology at Indiana University and the Associate Director for Clinical Affairs at the Simon Comprehensive Cancer Center. And it is my pleasure to have Dr. Reshma Jagsi, Chair of Radiation Oncology at Emory, with us today. Dr. Jagsi, congratulations on presenting your study idea to the group. It was really a great example of how radiation oncologists are tailoring, bespoking, if you will, treatment for our breast cancer patients.
Thank you.
Tell us, what is your major take-home message with this trial?
So the IDEA trial was a trial that was a 200-patient prospective multi-center cohort study. What that means is that all 200 patients had characteristics that met certain eligibility criteria. So they were between age 50 and 69. They all had a lumpectomy surgery to remove a single focus of invasive breast cancer. That breast cancer was sensitive to hormones, ER and PR positive and negative for something we call HER2, and it was evaluated with a commonly used test, a 21-gene assay known as Oncotype DX recurrence score, and that recurrence score was less than or equal to 18. And what all these 200 patients agreed to when they agreed to participate in this trial was to receive that lumpectomy surgery and the standard of care medication, which is an anti-hormonal endocrine therapy for at least 5 years, and not to receive what is currently the standard of care for patients in that age group, which is radiation therapy. In the study, our primary goal was to look at outcomes at 5 years to inform subsequent studies of whether this is a safe approach to consider further. And what we found was that indeed, at 5 years, there were only 2 of the 200 patients whose disease had come back, one in a lymph node in the armpit and one in the breast itself.
Fantastic. Now, I really enjoyed your part of the presentation where you showed how your study is complementary to other studies, specifically DEBRA or BR007. I must say I'm a little worried that some may think the question of radiation in this population is answered by your study and therefore be less inclined to participate in DEBRA. What would you say to those people who may be less inclined to participate?
So as I emphasized in my presentation, this was a small initial study to determine whether it would be safe to continue to explore this question. The large National Cancer Institute-supported DEBRA trial, NRG BR007, is a randomized study that is assigning patients to radiation or treatment or not, who are very similar to those who were enrolled in IDEA. And what IDEA shows is that this is a very reasonable and safe study to be conducting, but by no means is IDEA definitively establishing that it's safe to omit radiation treatment. As I said, these women were aged 50 to 69. These are women we expect to live for many decades, and so 5-year results like we've presented here are extremely early. It's incredibly important also to have information from this randomized study where half of the patients are actually going to receive radiation to better understand the impact that omitting radiation has on patients' quality of life, because you could imagine a world in which a patient who omits radiation might then have additional worry about recurrence or might have additional side effects from that hormonal medication, that anti-hormonal treatment, that endocrine therapy, if she feels like now this is all she has to rely on because she didn't get radiation treatment. And so it's incredibly important for us to enroll on this trial.
Fantastic. One last very quick question. Your trial looked at women who had a recurrence score of 18 or less. I'm wondering, given the great results of your trial, if we should take sort of an approach similar to MA39 and raise the eligibility to recurrence score of 25 or less.
It's a really good question. I think that given how well the accrual is proceeding to the current NRG trial, and the fact that this is a patient population where our tolerance of recurrence is going to be very low because radiation treatment is so well tolerated itself. We are now able to deliver radiation treatment efficiently. Most patients are receiving only a handful of treatments of radiation at this point. It is efficient, it causes few side effects, and so one would not want to tolerate very much of a risk of the breast cancer coming back without radiation to give up something that actually doesn't cause that much harm to begin with. And so I favor continuing with the relatively conservative cutoff that's in place right now. And then once that has been evaluated in the long term, if we find that that is safe, then to consider including patients who might be at higher risk.
Thank you very much. And again, congratulations on your study.
Thank you.